Good afternoon. First of all, I would like to thank the organizer for the kind invitation. This is the outline I will be following within the next 10 minutes. Diagnosing NAFLD, that is steatosis, diagnosing NASH, diagnosing advanced fibrosis, which is the most relevant endpoint, are this patient at the most at risk of developing complication. These are the non-invasive tests available: serum biomarker, non-patented and patented. And I will focus on FIB-4, NAFLD fibrosis score, and ELF, and elastography. And I will focus on CAP, VCTE, and MRI-PDFF and MRE. Critical issue when using non-invasive tests are availability and costs that need to be taken into account. So regarding the diagnosis of NAFLD, CAP, or MRI-PDFF, CAP comes on VCTE. Result range from 100 to 400, and MRI-PDFF stands for proton density fat fraction. So what are the advantages and disadvantages? CAP is a point-of-care technique, widely available already, and allowing concomitant liver stiffness measurement. The main disadvantages are the fact that quantification is suboptimal, quality criteria are not well defined, and applicability is reduced when you're using the M probe. MRI-PDFF is highly sensitive. It allows very precise steatosis quantification, and actually it can be considered the gold standard, even better than the liver biopsy, and it takes the whole liver into account. Disadvantages: it's time consuming, the availability is limited as you need an MRI facility, and cost also is an issue. What about the performance and cutoff? We have two multi-center studies, one from the US using the XL probe. And as you can see, for detecting steatosis, the ROC is 0.76. And with a cutoff of 285, you achieve PPV of 99%. But as you can see, there's a decrease in ROC with suboptimal performance for quantification. As for the UK study, using also the XL probe, similar number of patients and BMI, you see the ROCs are slightly higher. Again, with a cutoff of 300, PPV is 97%, and again, suboptimal performance for quantification. What about the comparison of CAP versus MRI-PDFF in these three studies? As you can see, CAP was outperformed by MRI-PDFF, both for detection and grading of steatosis. So in summary, CAP is a promising point-of-care technique for rapid and standardized steatosis detection, suboptimal for quantification, no consensual cutoff, but value above 275 have high positive predictive value above 90%. MRI-PDFF is the most accurate technique for detecting and quantifying steatosis and outperforms CAP, and thus more suited for clinical trial. Ultrasound in clinical practice remains the first-line tool despite its well-known limitation. What about now the diagnosis of NASH? This slide summarizes the different serum biomarker and elastography techniques that have been tested, including VCTE and MRI. And to make a long story short, none of these NITs are sensitive and specific enough to differentiate NASH from simple steatosis. Thus, liver biopsy remains the reference. What about diagnosis of advanced fibrosis for serum marker? This table summarizes the different meta-analyses with NAFLD fibrosis score, FIB-4, and ELF that are the most validated markers, and you see ROC are pretty similar in the range of 0.80. So we have patented and non-patented tests. So FIB-4 and NFS, they are simple and free, can be performed at bedside or in the outpatient clinic, widely available. Acceptable accuracy. We have large meta-analysis, as I've shown, and in clinical practice, they have high negative predictive value above 90%. For instance, a FIB-4 below 1.3 has a 95 negative predictive value. Disadvantages: they have modest positive value, below 70%, undetermined result in 30% of cases, and there's still the debate on the influence of age, especially for FIB-4. As for ELF, slightly higher performance, as I've shown, higher specificity, but not as well validated as the two previous ones, limited availability and cost that may preclude its use in practice. And this is illustrated in this study with a head-to-head comparison of these three tests. And even though ELF performed slightly better than NFS and FIB-4, widespread application was limited by cost and availability. What about now elastography? This table summarizes a different meta-analysis, and as you can see, the largest number is for VCT. This table summarizes the respective advantages and disadvantages of the different technique, and you can see that VCT is clearly the technique of choice because it has the highest level of evidence in NAFLD. It allows fat detection and quantification. The failure rate is below 5% when you're using the Excel probe. It's a point-of-care technique widely available at an acceptable cost. Now, the issue is that in practice, transient elastography has high negative predictive value, but suboptimal positive predictive value for F3, F4. So, for instance, if you look and you set a cutoff value that is low, 6.5 to 7, in order to maximize the sensitivities, you see that the negative predictive value is high, around 90%, but the positive predictive value is much too poor to be used in practice. If you're using the Uden index, maximizing sensitivity and specificity, you can see that the negative predictive value is still good, and you increase the positive predictive value. If you want to maximize specificity, then the cutoffs go from 12 to 14, and still you have around 30% of false positive patients. So in summary, FIB-4, NFS, and ELF and VCT are the most accurate and validated non-invasive tests for assessing advanced fibrosis. FIB-4 and NFS are widely available and easy to use with high negative predictive value for ruling out F3, F4, thus more suited as first tests for primary care, for instance, whereas ELF and transient elastography are less available and more costly with higher PPV for ruling in F3, F4 and more suited as second tests for secondary care. So if you want to combine these two tests, what is the best strategy? Is it a paired combination, serum marker plus elastography, or a sequential using either blood test plus blood test or blood test then VCT? The pair combination have been tested in this large European cohort, 700 NAFLD patients, tertiary referral center. And what you can see, if the FIB-4 and transient elastography are concordant for the absence of advanced fibrosis, you misclassify around 3% of patients. The issue are the indeterminate result. When they are discordant, it's more than 50%, and then a liver biopsy is needed. And overall, you correctly classify less than 50% of your patients. What about sequential combinations? This strategy has been tested with the FIB-4, for instance. As I mentioned before, around 30% have indeterminate result. If you use a second test, more specific, like ELF or VCTE, then you decrease the indeterminate result to around 13 to 23% as compared to more than 30%. So these are my take-home messages. Ultrasound remains the first-line tool for detecting NAFLD. Liver biopsy remains a reference for diagnosing NASH. FIB-4, NFS, ELF, and VCT are the most accurate and validated non-invasive tests for diagnosing advanced fibrosis. Optimal strategy is a sequential use of FIB-4 or NFS to rule out F3, F4, then VCT using the Excel probe to rule in F3, F4. And in clinical practice, we propose the following algorithm in patients with suspected NAFLD. Of course, first of all, you need to rule out other causes of liver disease, including alcohol, HBV, and HCV infection. Then you need to rule out advanced fibrosis using serum biomarker, either FIB-4 or NFS. And for instance, if the FIB-4 is below 1.3, the negative predictive value is very high. And then these patients are low risk of developing or having advanced fibrosis. Then you just need to attempt lifestyle modification and exercise. They don't need further assessment, and evaluation need to be repeated every 1 or 2 years. When FIB-4 is above 1.3, these patients are at intermediate to high risk of having advanced fibrosis and need to be referred to a specialist. A second test, more specific, will be performed in the liver clinic. This test is VCTE, and if liver stiffness is below 8 kilopascal, this patient are at low risk of having advanced fibrosis. And again, you should attend lifestyle modification and exercise and consider repeating evaluation after 1 year. On the contrary, for those above 8 kilopascal, you might consider liver biopsy according to local availability, and for instance, if this patient is eligible for a theatrical trial. In case of failure, for instance, you can consider other technique. Thank you for your attention.